Content is coming soon. Content is coming soon.
Hello, everyone. It's a great pleasure to welcome you to our masterclass on management of abnormal first semester screening results. We'll have three interesting presentations, and the first ones will be done as a joint presentation from our president, Katia Bilardo, together with Francesca Gratti. And well, I'm looking forward to your presentation.
Good morning. Welcome to this masterclass, which will be given by me. My name is Katia Bilardo, together with my colleague Francesca Romana Garatti. We will discuss the management and counseling of NIPT results other than trisomy 21. The first case is a 35 years old woman at her third pregnancy with two healthy children and an unremarkable past medical history. The conception has been spontaneous, and she presents after counseling and after a DETI scan at 10 weeks, and she chooses for an IPT at 11 weeks. The result of the NIPT is indicative of trisomy 18, an increased risk for trisomy 18. The counseling is that an increased risk for trisomy 18 can be the consequence of a confined placental mosaicism or a true fetal mosaicism. Therefore, the preferred confirmatory test is the amniocentesis because this investigates fetal cells. However, the pregnancy is still 12 weeks and 4 days, and the woman is not prepared to wait for an amniocentesis, and she wants some guidance now. The best option that we have
Helia, you're live.
Okay, for the first time, this is the first virtual World Congress from ISUOG, the International Society in Ultrasound Obstetrics and Gynecology. Welcome to all the audience that are joining this first Congress. Despite the time difference, it's really a pleasure to join this special Congress by the first time from all places. So I have the honor to introduce my colleague and one of the most prestigious person on fetal interventions, Magda Sanz, that is going to join these sessions that is the future of fetal surgery. For the first time, our first guest is Magda with the issue updates on minimally invasive repair for fetal open neural tube defects, the long-term outcomes. So we welcome everybody to this first virtual Congress and hope that everybody enjoy this first Congress. Be welcome.
Hi, my name is Magda Sanz Cortez, and this talk is on updates on Peroscopic Spina Bifida repair and long-term outcomes. Once MOMS trial provided the results showing how open hysterotomy spina bifida repair in utero was able to provide significant benefits, especially to the baby, different authors around the world formulated the question whether, if they were able to obtain a watertight closure of the spinal defect, if the same benefits will be provided to the baby. There's different approaches for minimally invasive repairs of the spina bifida. There is the mini
augment equipment. That means you should not
The question of whether or not we should operate on stage 1 TTTS was recently addressed by an international randomized trial. The equipoise for the trial was based on the results of the first international trial published in 2004, which suggested that laser was the best first-line treatment overall, but did not specifically address the case of stage 1, given the small numbers included in the trial at the time. Furthermore, several observational cohorts suggested that stage 1 could be successfully managed without surgery in up to 60% of the cases. The benefits of surgery were therefore debated, since the risks of intrauterine surgery, including premature rupture of the membranes in up to 40% of cases, miscarriage or preterm birth, intrauterine fetal death, twin anemia, polycythemia, sequence, and chorioamnionitis, may be worse than the outcome of the natural history of the disease itself. The inclusion criteria for this trial were asymptomatic stage 1 TTTS with a long cervix. That is, only patients with TTTS defined by oligohydramnios in one twin and polyhydramnios in the co-twin without Doppler anomalies, without polyhydramnios-related maternal symptoms, and with a cervix longer than 15 millimeters. Patients willing to participate were randomized by a central internet-based program either to immediate laser or to expectant weekly ultrasound follow-up. In these patients managed expectantly, rescue surgery was really available in case of progression in Quintero stages, maternal symptoms such as dyspnea or contractions, or rapid cervical shortening. The primary outcome was defined at the neonates level by a composite outcome combining death or neurological anomalies at 6 months postnatally. 100 patients in each arm were required for the trial. In the end, nine centers participated in France, the United States, Netherlands, Germany, and Belgium. The trial started in 2011 and ended in late 2018 with 117 of the 200 initially planned inclusions, when the DMC, the Data Monitoring Committee, chose to end the trial because of slow inclusion rate. During the inclusion period, no severe adverse event was declared, and the analysis we present is based on the 6 months postnatal outcome. Overall, during the inclusion period, 164 pregnancies with asymptomatic stage 1 TTTS were eligible. 47 refused the trial, and 117 were randomized between immediate laser and expectant management with weekly ultrasound follow-up. Within the 58 cases allocated to expectant management, about 40% remained stable throughout the course of pregnancy and were delivered without surgery, where a rescue surgery was performed in 60% of these patients because of progression in stage, maternal symptoms, or cervical shortening. At 6 months postnatally, 89 and 92 infants were assessed for primary outcome in each arm, with less than 5% of loss to follow-up. The results of the trial show that there were no